Welcome, everyone. Five Wishes is pleased to present today's Practice Community webinar, Advanced Care Planning with Rural Communities. My name is Jennifer. It's my pleasure to facilitate. We are recording the call, and we did mute all participant lines. If you need help, please email 5wishes@compartners.com, that's numeral 5 wishes, or send a message in the chat box. If you're listening over the phone and you need help, please press *0 for the operator. This presentation will last up to 60 minutes, and you are encouraged to ask questions throughout our time here. Please do submit a question by typing it into the chat box in the lower left corner of your screen, and do be sure to click on the send button. Do also take a look at the links box located above the chat area. Simply click on the link of your choice and a separate window will open. This will not interfere with your viewing of the program. It's now my pleasure to introduce Kathleen Taylor, who will guide us through today's program. Kathleen serves as the Five Wishes Healthcare Program Advisor, bringing more than 25 years of experience in advanced care planning, patient care, program design, and professional training. Kathleen, welcome.
Thank you so much, Jennifer. I appreciate that. And thank you, everyone, for being with us today to talk about the topic at hand. I want to remind you before we begin that the Five Wishes Best Practice Community is this collaborative that you are in right now. So anyone who uses any component of the Five Wishes Program for Healthcare is part of the Best Practice Community. And our goal with all of us together today and always is to enhance your outcomes and elevate your advanced care planning practice by sharing best practice stories like we're going to hear today, some resources, information, and anything else. We were just talking before the conference about the fact that there are people who've created models already, and if we can share them, that gives everybody else a leg up in doing good advanced care planning work. So we're glad you're here to listen and share. If you have questions, I want to remind you during the presentation, please submit your question by typing it into the chat box in the lower left corner of the screen, and then just make sure that you hit send. All of the presenters will be able to see the questions and will respond to them live if we can, or we may group some of them together, but if we don't get to you, I will get back to you after the webinar and make sure we answer anything else that's hanging out that we don't get to during the presentation. What we're going to focus on today, of course, is advanced care planning with rural communities. A lot of advanced care planning conversations happen in palliative care consults and palliative care delivery, and I think that's because one of the things that has happened is palliative care has, this is a different discussion, but good, bad, or indifferent, has gotten the attention of serious illness providers. It's also kind of, and I think this might be a mistake, becoming synonymous with end-of-life care. We can redirect those conversations as we need. But what does end up happening is a lot of advanced care planning conversations take place in that context. But we need to remember that only 17%, that's 17% of rural hospitals have palliative care programs, and that's compared with 90% of hospitals in cities. And there's much, much fewer community-based palliative care programs all across the country, and particularly in rural communities. So there are tremendous benefits to good person-centered advanced care planning conversation, and that includes, as we all know, increased access to palliative care and hospice services, improved outcomes for survivors, better satisfaction with care, fewer hospitalizations, fewer ICU days, and all that good stuff. In rural communities, there are some access barriers and there are some perceived access barriers to doing advanced care planning. But the truth is that most barriers can be addressed or overcome or sometimes even leveraged. And advanced care planning conversations can focus on what does matter to folks rather than what they fear or what the barrier is that sometimes we are the ones who perpetuate that and think we can't overcome that. So today, we're going to identify and reframe some of those challenges. We're going to highlight some real-life best practice examples of successful rural advanced care planning programs, and you're going to hear some tips and some guidance for building or enhancing your own rural-based programs. And before we do all that, I just want to real briefly reorient us all regarding the practice of good advanced care planning. There have been some recent articles. If you are an advanced care planning nerd like myself, you might have read them. The headlines have been about the usefulness of advanced care planning, but I think the headlines are, I think the semantics are incorrect in the headlines. I think what they're talking about are living wills in a vacuum. And I think hopefully everyone on this webinar knows that a living will in a vacuum is likely not that useful, particularly if it's done when someone doesn't have any idea of what might happen with their condition. So I want to just briefly review. Effective advanced care planning is going to have all of these components. It's going to include, of course, an exploration of values, concerns, and experiences with illness and end of life, someone's culture, their goals of care, and all of those components of a serious illness conversation, trade-offs, what it is that they want to achieve out of this, and of course, communication styles and preferences. All of that needs to be explored in good advanced care planning. And of course, 5 Wishes and the folks you're going to hear from today have some tools for how to do that. It should also include education and information sharing so that we ensure informed decision making. And that is likely to include some disease-specific education as people want it and as they prefer to receive it, and some information about treatment success rates, again, as people wish to have that information or wish to receive it. Ongoing conversations between the person who is making decisions and their loved ones, their health team, their support system, really it's any stakeholder in this person's choices. Those conversations should be ongoing and revisited anytime there is a change in a person's condition or their support system. There's, of course, the living will, which is, it's not just making the choices, it's doing a good job eliciting those choices and helping people understand what they mean and then clarifying those choices. The designation of a healthcare agent, again, that involves helping people understand what those responsibilities are and who would actually be good at doing that and help their wishes to be honored. That's a really important piece, too. I think, if anything, having a healthcare agent documented is something we want to make sure is in the electronic health record. And then with regard to the health record, having clear, unambiguous, and accessible documentation that's actually referred to when decisions need to be made and need to be informed by advanced care planning. So it's not a living will in a vacuum. And I just want to kind of have us all advocate for that. When you are expanding, when you're looking at program focus, to make sure that people understand there's a lot to it, and that's why we have a comprehensive program with 5 Wishes, and that's why we have things like what we're doing today, where we want people to give each other some information that can help everybody do really effective, compassionate advanced care planning conversations. So now that we've got all of our feet on the ground about what good advanced care planning is, I would like to introduce our speakers for the day who are going to focus us on effective advanced care planning in rural communities. First, we have Dr. Michael Frackkin. He's the Chief Medical Officer with Resolution Care, now a Vinca company. He's a father, a husband, a brother, a son, and a physician. And he's dedicated to the well-being of his community, which he's served in primary care in a community clinic system, as a medical director for the local hospice, a leader in the community hospital, and mostly a transformative voice for improving the experience of people facing the end of life. Dr. Fratkin created Resolution Care, now a Vinca company, to ensure inspired, capable, and compassionate care for everyone everywhere as they face the challenges of serious illness. We also have Maureen Tyra. She's the Director of Social Support Services at Resolution Care. She's a licensed clinical social worker who studied at the University of Michigan. 7 years as a hospital social worker in oncology and hospice for North Memorial Health in Minneapolis led to a passion for working in palliative care and advanced care planning. And she spent the next 4 years as a coordinator of advanced care planning for that health system. Life brought her to California, where she recently joined Resolution Care and found the perfect opportunity to use her expertise in palliative care and advanced care planning to support the growth of their social services team. We also have Jackie Heater. She's the project manager of population health services with Mercy One. She's a grant project manager for the Mercy One Population Health Services in Des Moines, Iowa. She leads 2 Health Resources and Services Administration, or HRSA, grants to improve advanced care planning services and improve documentation of advanced directives in the electronic medical record in rural communities. She has a bachelor's degree in child and adult family services and a strong background in social services and hospice care. So you're in great hands today with the panel that we've got to speak with you. And with those introductions, I'd like to throw it to Dr. Michael Frackkin to get us started talking about transformation in rural care. Michael,
well, here I am.
There you are.
I am. Yes, I am.
I don't
know how many of you.
Today.
Oh, it's such a pleasure. It's such a pleasure. There's like 100 people out there in the world that I can't see, but I'm going to ask them to imagine that we're looking at each other, eye to eye, talking this through, and tracking where the resonances are between the experience of the attendees and our experience here. Number one, I resonate with this slide because it reminds me of my favorite album, Dark Side of the Moon. My name is Michael Frackkin, Dr. Fratkin. I'm a father and a husband and a brother and a son, and I'm also a palliative care physician in far northern California. And what we've done over the last 7 years is take a situation where conversations related to advanced care planning and palliative care generally were not happening. And so we built Resolution Care as a initiative to bring high-quality palliative care and high-quality communication, conversations, and shared decision-making to the people who live where I live, which is a very geographically underpopulated and an economically disadvantaged environment. Next slide. Next slide. Ah, there it is. So the circumstance that led to our launch in 2015 was a vast unmet need, as I just mentioned, and my own burnout, as well as the heartbreak of me looking out at all the clinicians and healthcare professionals that I work with, struggling as well with burnout and displacement from the thing itself, which is helping people to understand what they're facing and helping them to be empowered to make the choices that they need to. And I won't tell you the long and interesting to me story about how we grew, but at the end of the day, 7 years later, we've joined forces with Vinca, a technology company focused on interoperable and highly valuable context for advanced care planning, discussions, conversations, and documentation. We have about 340, 335 people under care. We have value-based contracts that allow us to care for people throughout the state of California. We use telemedicine, and we focus our attention on the people that need us the most, people with California-based Medicaid or Medi-Cal, it's called. Next slide. In terms of telemedicine, I think I'll tell the story of how I think about it. You know, it wasn't but 15 or 20 years ago, people wondered whether or not connecting in a hub and spoke model would get people connected to less capacity for specialty care. And through the initial structures, say at Washington University in St. Louis, as well as University of California, Davis, they built these very heavy hardware, heavy investment structures. But as time has gone by, we've all noticed that the smartphones in our pockets and the ubiquitously available high-speed internet connections can be a tool for connecting to people and providing healthcare services. And that's what we initiated at the very beginning. I won't get too deeply into the economics that lit our fuse, but the idea of engaging with health plans as a partner to provide for wraparound services on a value-based structure makes it possible for us to use a fully composed interprofessional team in a very nimble fashion to deliver less on how many visits can we do or how many RVUs can we generate, and more on how can we move the ball down the field to achieve the outcomes that are important to the people we care for, to my treasured workforce, as well as to the people writing the checks at the health plans. Next slide. So rural healthcare means that you meet people where they are. I'm sharing with you just a series of slides that I hope you relate to, that you hope you imagine. The people we take care of are poor. Many of them are alone. They're lacking in safe housing, adequate food, the caregiving that they need as they make their way through serious illness and the approach of their death. This is a series of portraits that I did with a dear friend of mine, a very talented photographer. Next slide. They lack connectivity. They are burdened by substance use disorder. They have mental health issues. They, like many of us, are creating lives on a foundation that includes trauma. Next slide. And they need us. And they are perfectly capable of running their own lives when empowered with information and the tools that empower them. This little fellow was a hobo with cancer who rode the rails for many years out of his life, had a backpack full of journals and poetry that was actually quite beautiful. But as his cancer progressed, he needed a place to stay, and our incredible social workers helped him figure that out. Next slide. Oops. The next slide.
Michael, I don't think you have a next slide.
Oh, good. Well, so we're reversing direction. Well, I guess that would be my segue then. I wanted to paint a picture of the practice that we have in palliative care and the kind of people that we're trying to bring these conversations to. And the practical partner that I have is Maureen Tyra, our Director of Social Support Services, who will take you into the next section of this discussion to tell you how we actually do that for these folks.
Sure, that's great. Maureen, if you can help us. I know what Maureen's going to address, and she's going to talk about how you do it and some tips and lessons. So, Maureen.
Thank you so much. I really appreciate the opportunity to be here today. I've been excited about what Resolution Care is doing to provide both palliative care and advanced care planning to rural Northern California since I joined the company about 6 months ago. And so I'm really happy to be able to share some of how that works with all of you. Next slide. So our organizational culture, I feel like it's so important that the culture foster and prioritize the importance of advanced care planning. So that is something that we have done really throughout the organizations. Everybody is aware that this is an initiative. Everybody's aware of our goals to reach a 90% completion rate for an advanced care plan for all of our clients. We have created a dashboard. We have very specific metrics that we report out on. So we keep everybody in the loop and hopefully kind of excited about what we're doing and the progress that we're making. We've also embedded advanced care planning training right in the orientation and onboarding of all of our nurses and social workers. So we've done presentations, about 3 hours worth on the advanced care planning conversation, how to complete an advanced directive, how to complete a post using the VINCA platform. And we recorded those so that everybody that joins our company is required to then view and get that same education. So we're all kind of on the same place, have the same foundation to work with. Next slide. So as I'm sure many of you are aware, there are a lot of challenges to the rural setting, and Dr. Fratkin went through quite a few of those. I've kind of broken them into categories. There's challenges around engagement. The people live far apart from each other and all of the resources. Getting people to those resources in and of itself is a challenge. There's a lot of housing insecurity and homelessness amongst our population. We have quite a few natural disasters. We have wildfires, earthquakes, massive storms, blizzards, things that can affect both the stability of our clients and their ability to connect with us. And then it's, again, as Dr. Fratkin said, it's sort of a less sophisticated community with regards to healthcare in general. People have a sense of just wanting the physician to tell them what to do. So concepts like care coordination and shared decision making, we kind of have to do some educating and engagement around that in order to proceed with our care sometimes. The second category of challenge is limited resources. Our Wi-Fi and cell service can be really poor, and we rely on that to do virtual care. There are limited medical specialists in the area, so many of our clients have to travel hundreds of miles to get particularly their specialist care. There's very little hospice care, little home health care, caregivers. There's a lack of skilled nursing facility beds. So all of those things present challenges to creating the stability that we need our clients to have so that we can then provide the good care. And then finally, again, as Dr. Fratkin said, there's a lot of substance abuse in that area. There's a high incidence of methamphetamine use with people with CHF and COPD that was induced by that. There's also a high incidence of alcohol-induced liver failure. So a big part of what we do is support the maintenance of sobriety for our clients along with the bigger picture of their care. Next slide. So how do we address these challenges? Well, we start with the basic kind of social determinants of health issues: income, housing, their social support, getting them caregivers, transportation, and then connectivity with us. We have to get all of that in place in order to provide the other care. So some of the practical things we do is we have the ability to provide tablets or cell phones to our clients if that is their need. We provide them with the tech support to problem solve, make sure they understand how to work the device, that they have that Wi-Fi connection. Sometimes we have to help them find a place to get Wi-Fi if it's not available in their home setting. So we'll connect them or help them problem solve using friends or family or sometimes even their primary care clinic so that they have a place that they can rely on to be able to Zoom in with us for our video conference meetings. Our staff has become really expert at Social Security income, Social Security disability, and that's one of the things we do first with people that don't have income. So again, they've got that reliability. It helps create the stability that we need to move forward. We work really hard on forging relationships with our community service providers so that we are mutually supportive. We're helping them provide better care and to our clients, and they are helping us, and we have to have those stable relationships to be able to engage and hook our clients in. We have a few community health workers who do boots on the ground work when everything else fails. So we do have a few people we can send out to the doorstep if we need to for delivery of a device or support for that. And then we do a lot of education around the concepts of palliative care, care coordination, shared decision making, things that empower the clients and kind of foster their autonomy, and then also help build trust and engagement with us. And again, with this population, we find that we really need to get in there and do some of that work before we can move into the whole advanced care planning realm. So once we've got that in place, which we try to do pretty quickly within the first week or two of care, then we move on to advanced care planning. And we try to, at that point, kind of help them understand that it's a benefit to them, that it's a gift to the family, all of the good things about it that we know, but that are sometimes misunderstood by the community at large. Next slide. So specific processes that we follow, we try to introduce advanced care planning as part of the intake process with our clients so that, again, we kind of plant that seed, ask about advanced directives, are they familiar, and then let them know that this is something we're going to be circling back to. We ask our providers to kind of normalize and set the expectations for having that conversation. When we do video conferencing and we enable that to make sure that we've got that connection with people, that we've got that visual, if at all possible, so that we can get to know them and they can get to know us. We do use a phone as a backup option for times when the video conferencing isn't available, and it may take us sometimes a few weeks to really get that stable, but it's always the end goal. And then embedded in our process is reviewing advanced care planning status at every interdisciplinary team meeting that we have. So as we do those meetings and we go over the clients and what's going on with them, we always touch on what's the status, have they had a conversation, do they have the advanced directive, where's the post and completion, so that it stays high on the radar screen and is continually being addressed. Next slide. We've asked our social workers and nurses to really take responsibility for moving that advanced care planning conversation forward. We always want to keep in mind kind of the social work tenet of meeting the client where they're at, leading with empathy, trying to create baby steps to move things along. We present, as you know, that advanced care planning is a gift to family and loved ones. It's going to help in a time of stress. It's going to help in a crisis. So it's something that, if they can engage with us now, it's going to make everything go smooth later. So we kind of keep circling back to that. We talk about that concept of living well. What's a good day look like for you? What do they understand about their illness and its progression, and what's important to them in maintaining their values around quality of life as much as possible? We schedule our meetings specifically for an advanced directive or a post as we're doing our cadence of other visits with providers and with nursing. So we kind of try to look ahead at where the person's at, plan specifically, get that scheduled so that everybody has the opportunity to touch on it and move the conversation forward. We also want to keep in mind that sometimes it makes sense to invite the agent and family members to our video conferencing sessions. Sometimes that really can help get their buy-in and their support. And again, as you know, having everybody understand the nature of the conversation and support the values of the person is how we're going to make sure that they get the care that they need. And then finally, through the VINCA platform, we do have e-signature options for both advanced directives and posts. And then we can also do the e-signature with witnesses for advanced directives. So there are times when we will try to get everybody available so that we can have a signing and witnessing section. And then we're looking into opportunities for using an e-notary. And we also have resources for mobile notary so that to get that entire document completed, signed, put away, so it gives them that security, and it gets us the information that we need to provide them the care that they're looking for.
Maureen, can you talk just a little more? This is an area that is a challenge for a lot of systems, and I want to just take a moment and ask you, because I know you've got an answer to this. Can you talk a little bit more about the solution that you use to do some of the things you're talking about with documenting in the electronic medical record?
Sure. So both the electronic medical record, but I think you might be also talking about the VINCA platform. So those two things kind of go side by side with us.
Right.
Is that what you're referring to? So using VINCA, we are able to, through video conference, we can pull up the VINCA platform, which has the 5 wishes form sort of embedded in it. And then we will generally screen share so that we can do a facilitation session with our client, with whoever's present with them, and walk through all of the steps, all of the pages of that advanced directive form with them. And we can electronically fill it out and they can see what we're answering. We can type in information and review it so that we're getting the wording correctly and they're seeing exactly how the form comes together. And the other thing I want to say that's really cool is you can stop at any time and save your progress and go back in. So again, there are times when we can't have a full conversation in one session, but we can go pick up on it and use that platform to start where we left off. Once we have it completed, that electronic e-signature piece allows us to connect with them through their smartphone and turns the smartphone into like a signature pad where they can literally sign the document and we can watch in real time as their signature shows up on the form and they can see that. We can then connect to their witnesses if they are available, do the same thing, and have a fully completed advanced directive form or post. Similar process, walking through, getting all the boxes checked, having those conversations, and getting their signature on the form. And then we store that. We're in the process of connecting that to our electronic medical record so that the form goes and is stored securely there for us, but we also print it out and mail it to people so that they have a hard copy at their home.
Thank you. That's really helpful. And I think anybody who's got questions about that, if you type them in, we'll get to those either on the webinar or afterward. And just real quick, as you're going through, we had someone ask for a refresher about what is POLST. POLST stands for Physician Orders for Life-Sustaining Treatment. There are, most of the states in the country have a medical order that has typically either those initials or MOST or MOST or something like that, but that is a actionable medical order for life-sustaining treatment. So a little bit different than advanced directives, but also a medical order regarding end-of-life care. Just throw that in real quick. Thank you.
Thank you. I always like to say that the POLST and the advanced directive complement each other. So the advance directive is your legal form that gives authority for an agent to speak and is the reference for what your wishes would be in a medical crisis. But like you said, the POLST is the medical order that would go along with that if that person does not want CPR or intubation or any of those more invasive life-sustaining treatments. It's a document that they need to have signed so that it can be followed by medical professionals out in the community. Next slide. So just want to highlight again some of the tips and tricks that we have come up with to move this process really fully into the work that we're doing with our clients. We encourage all of our employees to complete their own advance directive because, again, it's kind of a theoretical thing until you've done it for yourself and wrestled with some of those questions. And I think it helps people to really understand what it is that we're asking our clients to do. We also encourage our employees to do an advanced care planning session with friends and family so they get that practice of going through the form and doing that facilitation piece and, again, how to approach that conversation. And then having consistent documentation in the electronic medical record is really important because ideally you want to have the conversation be able to be picked up by somebody else moving it down the road. We all know that, again, it's not always easy to do just in one session, but if you have a provider present it and kind of endorse it and make a few notes, and then a nurse or social worker can pick up on that, know where those notes are, be able to find that saved form and pick it up and move it forward. So that documentation in the electronic medical record becomes really important. Also, just making sure that you're labeling and storing your advance directives and POLST consistently, having the same title for them because, you know, we call them health care directives and advance directives and healthcare proxies and all different things. So you want your organization to settle on verbiage and use that really consistently. And then finally, that normalization of the conversation is so key to sort of de-stressing people because, as we know, nobody really likes talking about death. That's something in this culture we sort of avoid and hope is never going to happen. And so setting the expectation that everybody over the age of 18 should have an advanced care plan, that this is a conversation that starts when your parent's authority ends when you become an adult, things that kind of plant that seed of this is something that is just part of routine medical care, not something that we're bringing up because we think you're at the end of your life. So we really want to, again, plant those little seeds and normalize the conversation throughout the care that they're getting with us.
And Maureen, we've got a question from Julie. You'd mentioned community health workers as part of the advanced care planning program. Are they actually involved in the advanced care planning process? And if so, how? What piece are they doing?
They are actually not so much involved in the advanced care planning conversations, but more in the connectivity with our clients to make sure that they have that Wi-Fi connection or the device or whatever they need to be able to have that conversation with us.
Great. Thank you for that clarification.
Next slide. So just, again, some quick lessons learned from doing work in this rural setting and in palliative care. It's much the same as it is everywhere, but just with a few extra challenges. It's keeping in mind that key framework of normalizing, aligning with the clients, engaging with the clients, helping them understand what the goal is and having that mutual goal, and then keeping in mind that you really can't rush the conversation, that it's baby steps, it's planting the seeds, moving things forward a little bit at a time to get to a really more robust, more in-depth, meaningful advanced care plan and advanced directive if you do it that way. And I think that's the end for me. Thank you so much. I appreciate everybody.
Thank you, Maureen.
I'll be available.
And we've got a few questions trickling in, and we'll, I think, go through the rest of our content, but some of these you might be able to help address. And I just want to say I particularly appreciate and want to highlight the first thing that you spoke about, which was addressing the social determinants of health first. This, to even engage in these types of value-based conversations when people are unable to feed themselves. I think that is such an important piece of doing work with communities that have limited resources to address those needs first. And you did such a beautiful job talking about how you all do that. So thank you for that piece. Appreciate that.
Thank you. Yeah, I agree. It's really important and almost respectful of where they're at and what their most urgent need is, which is that stability, before we can get into what sometimes feels like our more urgent need, which is understanding what their wishes are.
And that, with the way you just framed that, I want to put a little flag in it and come back to it at the end, because I want to talk about outcomes and outputs and how we capture those. So just consider that for later. But I want to get to Jackie, because she's got some wonderful things to share with us about how they're doing it in her community. So Jackie, I'm going to throw it to you.
Hello, everyone. Thanks. I'm very happy to be here today to share what we're doing in Monroe County. I work for Mercy One, which is an affiliate, Monroe County Hospitals and Clinics is an affiliate of Mercy One, and the Your Choice Advanced Care Planning Project is happening right now in Monroe County. And before I get started, I want to say that Mercy One and I have no financial or business-related conflicts of interest to disclose. My presentation today is not a promotion of any product or service provided by Aging with Dignity or Five Wishes. So next slide, please. In Monroe County, we have Monroe County Hospitals and Clinics. It's a 25-bed critical access hospital and rural health clinic in rural southeast Iowa, and like I said before, it's an affiliate of Mercy One, which is a larger statewide health system. We have some challenges common to rural communities. Our population is under 8,000. We have a higher elderly population distribution, a higher incidence of chronic illness, comorbidities, and unexpected deaths. We have lower income and educational attainment than Iowa and the nation. But we are full of wonderful people that make great friends and neighbors. So there's always a good thing about rural communities. Next slide, please. So Monroe County Hospitals and Clinics and Mercy One partnered, and we were awarded a HRSA grant, Health Resources and Services Administration Rural Healthcare Services Outreach Program grant, and that grant is for 3 years. HRSA has helped us along the way with a lot of our structure, and the foundation of that structure is our work plan that includes these following goals. The overarching goal of our project was to advance a culture of understanding and use of advanced care planning among all Monroe County residents and healthcare providers, with Project Goal 1 being to improve access to advanced care planning services, and that means just to increase our services offered and make it easier for people to get advanced care planning services. Project Goal 2 was to increase the number of patients served by the consortium who have a documented advanced care plan. Basically, we just wanted to see more advanced directives in our community. We need to see them at the hospital and throughout our consortium organizations. Project Goal 3 was to create a shared understanding of what successful advanced care planning looks like and have consistent documentation across the community. We built this community consortium who acted as a guide, kind of like a board that guided the project. And it was made from those advanced care planning heavy hitters at first, like hospice, public health, nursing facilities, and then as the program gained traction, we opened it up and invited more community entities like assisted living facilities, the religious communities, some aging resources, and Veterans Affairs. Next slide, please. So how did we do this work? It's great we have this work plan, but how did we actually do it? Well, first of all, we utilized evidence-based and evidence-informed practice. We used Respecting Choices curriculum to increase access and create a network of certified facilitators to have those important conversations. We used 5 Wishes as the best practice documentation and for educational purposes. And then, like Kathleen was saying before, we used the IPOST, which is Iowa's version of the POST form, Iowa Physician's Order for Scope of Treatment. We also developed an educational and marketing outreach plan. We developed our own educational tools. I know there's a lot out there, but we decided we wanted our own. And so we developed an advanced care planning brochure, a CPR guide that talks about what CPR is and what CPR is not, and to help people decide if CPR was right for them. And we also developed a self-guided video when COVID initially hit, because we were seeing a decline in patients wanting to come in for services. So that self-guided video was to help people go through the advanced care planning thought process on their own with their computer or phone before filling out their advanced directive. We developed a pretty great website, I'd say, if I could say so myself, with lots of information and resources, and you can visit that if you'd like. It's www.mchalbia.com/yourchoice. We also advertised in local newspapers, had radio ads, and then social media ads. We learned that attending community events that were already well attended, instead of coming up with new ones, it was more effective at helping us provide educational resources and promotional items. We also participated in the Monroe County Hospitals and Clinics Wellness Incentive Program to encourage staff and their families to complete their own advanced directives, like Maureen was saying. And we found also that it built integrity for the program, and it had our staff, and once the staff went through their own process, they were better advocates for advanced care planning to our patients and throughout our community. We then developed improved workflows throughout the appropriate departments at Monroe County Hospitals and Clinics. And like what was said before, HIM, Healthcare Information Management, may not be one of the first places that you can brainstorm of where advanced care planning should be, but we saw that our advanced directives were not being scanned in consistently and or correctly. So one of our first workflows was with HIM. We provided education to the HIM staff on advanced directives, and then we developed a workflow to consistently scan in those advanced directives. They aired out old ones when it was appropriate, and they changed the banner bar in our EMR to indicate that the patient had an advanced directive on file. We had a workflow developed in the surgery department where the pre-op discussions included asking about advanced directives, and if patients didn't have one or wanted to update theirs, they gave referrals to our facilitators. The workflow in the hospital on the floor were developed where providers and facilitators had great advanced care planning conversations with patients and then documented them. And the emergency department is not a great place to start your advanced care planning conversations, but we still wanted to give them education on what advanced directives were and then how to follow through with the medical treatment that was indicated on our patients' advanced directives. We also had workflows developed in the medical clinic. So education was given to each of the disciplines, and registration then knew how to handle advanced directives when patients brought them in, and they were able to give out educational information and make referrals to facilitators also. Then providers and nursing staff, after, again, education, became more comfortable with advanced care planning conversations with patients and documented those conversations. Next slide, please. Lessons learned. Man, did we learn a lot, and we're still learning, that's for sure. Something we learned early on when we first got this grant, we wanted to get boots on the ground out there and educate the public, but when the public came in as a response of our outreach, we quickly learned that our staff needed to understand advanced care planning first because we weren't giving the right direction. So we learned early on that each department, every staff of our consortium needed to have education first to build that foundation. Then again, saying it again, we encouraged our staff and their families and loved ones to complete their own advanced directives. Like I said before, it built the integrity of the program, and it also made our staff and their families great advocates for the whole process. What I also learned is that advanced care planning is not common knowledge where we are. We learned early on that whenever we have a new stakeholder connection, whenever anyone asks me to present or to talk about the program, I always start it with Advanced Care Planning 101. In my experience, when people don't know, when it's not common knowledge around here, I've had anywhere from medical directors to my average friend or colleagues not really understanding it. So having that education be first and foremost builds a great foundation for us to build upon. I also thought it was important to put on here that we want to keep stakeholders informed. We can't have engaged key persons unless we keep them informed. We've learned that meeting with stakeholders regularly and keeping them engaged helps with sustainability. Creating a regular meeting cadence with those key roles helps engage them by getting them involved with activities. Asking them for help or co-facilitate activities also helps with that sustainability. What we learned with COVID too is that our Monroe County residents prefer those in-person discussions over our Zoom opportunities, or they did like the phone calls, but most of them wanted to make appointments with facilitators one-on-one. The biggest thing, I think, one of the biggest things, I guess, that we've learned throughout this process is to just keep trying. That we use the Pdsa Cycle several times with all sorts of different areas where we plan, do, study, act. We plan something, we do it, we see if it sticks. If it did, wonderful, and if it didn't, which it didn't a lot, we tried something else. And in addition to that, small changes can make a big impact. We've learned that starting with small changes, starting with those easy changes like the low-hanging fruit, can make the biggest of impacts. Next slide, please. So throughout this 3 years of our grant period, we've had some outcomes, some really great ones that we're proud of. We've had 11 consortium member organizations active. We have 20 Respecting Choices certified facilitators, 7 certified instructors, and we facilitated 302 unique conversations with our facilitators. We've had 5 major workflows improved at Monroe County hospitals and clinics. We've developed 13 different educational tools, and we've seen a 191% increase in advanced directives on file at Monroe County hospitals and clinics. Next slide, please. I'm a visual learner, so I love graphs and whatnot. So here's a graph showing that we had a 5-year baseline before the grant started, and there was 246 advanced directives on file. And through our 3 years of our grant program, we've increased that to 717 advanced directives on file. There was a 3 per month average of advanced directives, and now we've increased that to 20 average per month. Next slide, please. So looking at the 3 years individually, year number 1, we increased, we added 120 advanced directives to the EMR. Year 2 was 217, and year 3 we have an additional 380 advanced directives on file. And you can see here too that we've increased our average advanced directive per month to 31. So we're pretty happy with some outcomes even though we're still working. If you could, next slide please. Like I said before, we still are learning a lot. We're still continuing to see what works and continuing to improve our services. The next steps for us is that we're finalizing our sustainability plan for Monroe County because the grant is ending in April, so we're nearing the grant end, and we want to make sure that the work that we're doing now is continued when the grant ends. And so we're working on that sustainability plan. We also are really excited that we get to continue our work because we have been awarded another HRSA grant that is focusing on 2 additional rural Iowa communities. And so we're going to take what we've learned from Monroe County and spread and scale it to those 2 rural counties and throughout the Mercy One healthcare system. we're pretty excited about the additional opportunity of that grant opportunity. We're also going to prioritize understanding and being experts in advanced care planning, billing, coding, and tracking, because we just ran out of time and resources to be able to do that with this initial grant. That we'd really like to focus on that with the next grant. In my personal opinion, I think that the billing and coding and tracking regulations or guidance is vague. So if there's anyone out there who feels like they're an expert in that, I would sure love to have a connection with you. You can contact me through my email, and Kathleen would be able to provide that, and I can put that in the chat too if anyone would like to connect over that billing and whatnot. So that concludes my presentation for today.
Jackie, thank you so much. You guys have done incredible work. And I love the way you're talking about sustainability, because I think once you've experienced the benefits that advanced care planning can have in rural communities, you want to make sure that it's got, you know, that there's some teeth in it, and that the work doesn't go away when we have turnover in staff. That's something we see sometimes through the history of Five Wishes, and I've done a lot of work in the past with advanced care planning, and a lot of times it's personnel dependent and program dependent. But when you involve the community in it, as you've done with your consortium, and spreading that out beyond just healthcare providers, it becomes something that can be sustained and institutionalized past any of us turning over, or a grant ending, or a program changing its mind, to actually get the community to have awareness about the value. So I just love your whole project and hearing about it. That was great, everybody. We've had some questions come through that I thought maybe we could talk about as a group just briefly before we wrap up. The thing I'd like to address, I think, out of all of these questions the most, is to talk about outcomes for the people served. There are, of course, outputs where we measure things like advanced directive completion rates and such, and that's been one of the great frustrations of advanced care planning programs, is how do we talk about the value of what we're doing? We had one question come through about how does advanced care planning save systems money, and I'd like to refer that person and anyone else interested to the links section. If you go to the Five Wishes Best Practice community page, we have an archive of all of the webinars we've done before, and Roberta Geidner with WellSpan has documented their incredible work in terms of dollars saved for the organization, which is one way to look at the outcomes, but it's often a motivator for systems when you're looking at expanding advanced care planning into rural communities. And in general, sometimes those financial outcomes can make a big difference. But I also wanted to ask you all about things like miles saved for people served. I mean, if they're not having to come in to an office with resolution care, or things like access being increased just by the fact that you've given them some access to Wi-Fi, you've helped empower them to know how to use some of those tools. So even though these are less sometimes of what administrators want to hear, they're more of what I think we actually want to be doing and what human beings need. Can you talk a little bit more about how you have measured those types of human-centered outcomes?
I can speak quickly, and then I'll pass to Maureen. You know, we used to actually figure out the actual miles saved, so I really appreciate you asking that question. When we had a census of about 100, we estimated that we were saving $50,000 to $75,000, excuse me, 50 to 75,000 miles of staff and participant traveling. Maureen, do you want to talk a little bit about the outcomes that we measure and the impact on our our group?
I would love to. I don't know that I have those numbers at my fingertips here. I just know that, you know, in general, we have data showing that we are not only saving like miles and gas, but time hugely, both for our employees and for our clients, because they're able to be serviced right from their living rooms. And I know that we have data around decreased hospital stays and some of those kinds of things. But Michael, do you have more specifics on that?
Yeah, I can very generally say that in terms of dollars spent or avoidable acute care utilization, of which one of the levers is the conversations that we have related to advanced care planning. The rest is symptom control and otherwise engaging with people to solve social determinants of health. But in general terms, when a comprehensive, fully composed palliative care team functions in this way to provide home-based care, for every dollar spent for each Medicaid life, we have demonstrated that we save somewhere between $2 and $3 in avoidable acute care utilization while driving extraordinary patient satisfaction data as well as quality of life measures, symptom control, and other quality measures that we do. Now, what piece or part of that whole calculus is the advanced care planning and conversation? We can't parse it out, but I think what we can say is that these are the conversations that help us define people's goals, help us to join them, help us to engage their trust, so that as we advise them and provide them with alternatives to the default conveyor belt of the healthcare system, as fragmented as it is, they choose to bend their pathway towards that which our experience kind of guides them towards. Yeah, so save a bunch of money, make them very much happy, improve their quality of life, and engage their trust, of which these conversations are centrally important.
I think that's what it's all about. And certainly we can have more conversations on future webinars about outcomes and how to measure them and how to get creative with them and measure what really matters. I want to remind everyone that this webinar is recorded. We'll be sending out a link to the recording in an email in the next week or so. I also want to remind you to, real quick before we get off, look at the links section on your screen right now. We do have a link to all of the programs that were spoken about today. We also have a link to the 5 Wishes program for healthcare, where you can find the 5 Wishes resources that were spoken about, and you can find how to contact all of us. I would like to also remind you that if you have ideas for future webinars or if you have additional questions, please send us those ideas. And you can contact the president of 5 Wishes at this address or me at the address you see on your screen. And any questions we didn't get to in the webinar today, I'll follow up with an email and answer you individually. So thank you all so much for your participation. I'll throw it back to Jennifer.
Great. Thank you, Kathleen. As Kathleen mentioned, we did record the session, and we'll have the archive available. You may access the archive by visiting the 5 Wishes Practice Community page at 5wishes.org/practice and look under webinars. Feel free to share the page and webinar link with your colleagues. On behalf of the 5 Wishes, thank you to our speakers and, of course, everyone for joining today. Have a wonderful day, and you may now disconnect.